I want to welcome everyone to today's Department of Internal Medicine Grand Rounds. I have the real honor of introducing Dr. Hal Collard. I had the pleasure of knowing Hal for the better part of the last 20 years. We had an opportunity to train together. And so I've watched his career, the trajectory of his career to becoming an international thought leader in the area of interstitial lung disease, having published over 200 manuscripts. To give you a little bit of Hal's background, Hal conducted his training at Duke, where he received his medical degree. He subsequently completed a residency and chief residency at UCSF, fellowship at University of Colorado, after which he returned to UCSF, where he is right now. He holds several titles, including serving as the director of the interstitial lung disease program at UCSF, as well as associate vice chancellor for clinical research, and also the director of the UCSF CTSI. The title of his talk today is Gastroesophageal Reflux and IPF, My Journey Across the Clinical Research Landscape and What It Has Taught Me About Professional Success. It is really a pleasure to introduce a friend, a valued colleague, and actually a peer mentor as well. So with that, I'll turn it over to Dr. Collard. And Hal, thank you so much for joining us.
Yeah, thank you, Pat. Thanks very much. Thanks, everybody. Good morning, or at least it's morning here. Maybe it's just afternoon there. Yeah, it's great to be here. I really appreciate the opportunity, and I'm just sorry that it's not in person. But we'll do what we do these days and have a Zoom meeting. And as I was talking with Pat a little earlier, it actually has made communication across long distances work actually easier than having to get on a plane and travel. So in some ways, this is helpful to collaboration. I'm going to share my screen now, and maybe just if it's not coming across well, someone can tell me. So I hope that this title would be a little intriguing for you, and I am trying to use this topic as a tool for speaking a little more generally to my career and just how I've thought about the things that are important to success. And I just want to highlight in particular this time for our community. It's such a difficult time for us as a profession, particularly those who are just starting out, who are just beginning to build their funding, who have young families, trying to balance childcare and research. Of course, those affected by COVID-19, the recession, systemic racism, all of these issues that are front and center. So another reason I wanted to incorporate this kind of larger theme into this talk was hopefully to provide some reminders to you of the strength of our community and the opportunities you do have to succeed and get through this tough time. So it really is a pleasure to be here. Thank you again for the invitation. I like this cartoon from a few weeks ago, just to kind of highlight how strange it is to be talking to a group of you without seeing any of you. I don't even have the picture that this woman has. I just have my slides. So I can't tell what you're doing, but please don't worry about it. If I'm not interesting enough and you need to check your emails, by all means, please do what you need to do. But I'm hoping to keep you engaged and look forward to some interaction during this talk, actually, which I think technology will allow us to do. I have no disclosures to financial conflicts to disclose. I just wanted to make a comment about this grand rounds and the opportunity for us to connect across institutions. Something's definitely lost in this Zoom relationship. I think most relevant is the missed opportunity to spend time with you, at the water cooler or just in passing in the hallways to talk about interests, to share connections. I have found in my career that those moments are very important to building relationships, and those translate into professional opportunities. So I really hope that we have future opportunities to build more of that between myself and you, and between our institutions. Like UCSF, VCU is a premier urban public research university. You are 26 years older than UCSF. UCSF was founded in 1864 by a surgeon from South Carolina, actually, who came out as a gold miner and failed, so then set up a surgical practice. So we both have kind of rich histories, and I tried to learn a little bit more about VCU on your website. You've highlighted some important accomplishments. You had the first School of Social Work in the South, first organ transplants in Virginia, first university to receive significant NIH funding for translational research, which, as Pat said, is something I think a lot about these days. And then I was really glad to see that highlighted on my homepage was you are also the first men's basketball team to go from first four to the Final Four, which of course happened in 2011. You probably hear that from most everybody who visits. It's such a remarkable and fun story, but I remember that well. So it's great to be here. I want to try something in this talk, and hopefully you can see this. I don't know if any of you have used this before, but this is a real-time kind of interactive tool for PowerPoint. I've used it a little bit. It can be a little glitchy, but I think it is something I'd like to try to help us as we go through this talk, assess the impact of what I tell you on your perspective on this topic. So if you could take a moment, maybe some of you have used this before, to grab a cell phone, or you can use your computer. And you see at the top of this slide, you can either go to that website, and importantly, my last name has no D on it in this for some reason. That's just how it's set up. So Harold Collar with no D, 607, or you can text that name, Harold Collar 607, to the number there, 37607. And if you do that once, you'll join, and then we can test this out. I've just activated this slide. And you can vote for which is the better mascot. Yeah, so I think this should be a pretty easy question for you. And I see that, yes, the ram is winning over the spider. Very good. So good, it works. I think, Pat, you might want to do some investigating of the 14% if your institution is anything like ours. But it looks like the ram wins. Okay, so great. Thank you for doing that. So now I want to ask you a serious question just in preference. Well, I shouldn't say serious. That past one for Lottie was very serious. But a lot of my comments are targeted at trainees and junior faculty. So I'm just interested in kind of the percentage of the audience that fits into the trainee junior faculty member. So I'll leave this up just for a couple more seconds. And thank you again for those of you who are answering here. Great. So, okay, so somewhere between 20 and 25% of you are trainees and junior faculty members. Okay, and I know the rest of you are probably a mix of different backgrounds, a lot of faculty, maybe some community members. I hope this talk is of interest to all of you. All right, I'll have a few more of those polls as we go through the talk. So for the junior faculties and trainees, I have a couple of slides in here mixed throughout which have take-home messages, and I just want to highlight each of these briefly. I think the first one, and maybe the most important one, would be to find a mentor. And to me, a mentor is somebody who, yes, gives you scientific advice and helps direct your scientific career, but also really functions as what sometimes now is called a sponsor as well. Somebody who cares about you and who helps to look for opportunity for you. The good thing about institutions like ours is that there are a lot of people around who fit that description. And for me, this has made every difference. So I truly believe that behind every successful researcher, I put almost in just because it's good to never be 100% on anything, but behind really almost every successful researcher is a great mentor, and probably several. You shouldn't try to do this on your own. I don't think you can, but you shouldn't try to or feel like you need to. And don't feel guilty for support from mentors or sponsors. I have on here that payback is generational, meaning that you will, when successful, do this for the next generation of trainees. But actually, as a mentor myself, I'll tell you that payback is also immediate, both in terms of satisfaction, but also productivity. As I'll speak to later, probably the most important thing I did for my productivity was take on fellows. That's the way that team science really moves forward and good science really moves forward. So remember this, find a mentor, don't hesitate to ask. You need to go out and ask for it. For me, these were my two mentors. Talmadge King, who is now the Dean of the School of Medicine at UCSF. At the time I met him, he was at the county hospital affiliated with UCSF and was one of my first medicine attendings as a resident. And then with Pat and others, many others actually over time, I met Marvin Schwarz. Marvin, as many of you know, was the division chief in Colorado. So I trained with, worked with, and really identified with and learned from both of these two mentors. And they were both essential to my success and really selfless in helping me to find opportunities and direct me. Because the course is never straight. There were many twists and turns and questions and doubts, and that's normal. So use your mentors to help you navigate. One thing they taught me, and then I'll get on to the topic, I promise you, is to believe in yourself. So this is the other thing, that the imposter syndrome that many of you junior faculty probably feel. I certainly did. So just remember to believe in yourself. You can absolutely do this. Research, as you've probably heard, is a large percentage of failure, and successes are rare and few and far between, but that's just how it is. It doesn't mean there's anything wrong with you pursuing it. So keep believing in yourself. Don't look to others for validation and push forward. Okay, so what I want to talk about today, and what I was kind of brought to through my mentorship and my interest in pulmonary medicine, was this condition, idiopathic pulmonary fibrosis. My career has been focused on this condition. IPF is a devastating disease, as hopefully most of you know. It doesn't have a cure. It has a natural history similar to many of the most lethal cancers. When I started in this field, my first patient we had no real idea what caused it. We had no treatments. In fact, we used treatments that were later shown to be harmful. And we essentially practiced palliative care medicine for the estimated 100,000 Americans diagnosed every year with this condition. So I'm thankful and grateful to be able to say a lot's changed over the last 2 decades. We haven't cured this by any means, but we do have a much better understanding of the condition. And we have treatments which have important clinical impact. And this is all because of the research community, people like you. So I want to spend a minute on the pathobiology of IPF. And I'm a epidemiologist, clinical trialist. I'm not a mechanistic researcher. I'm not a bench researcher, but I spend a lot of time with them and I think a lot about this. So this is my summary of where the field sits and how I think about IPF and how I explain it to my patients. Fundamentally, and this may not be new news to you as much as it has been in the past, but IPF is really, as I think of it, a disease of the alveolar epithelium, and it is a dysfunction of those cells and a loss of ability to regulate the environment and control scar formation or fibrosis. Particularly in the setting of injury, or stress maybe is a better word. And this injury and stress doesn't have to be anything kind of out of the usual day-to-day stress of an organ that is exposed essentially all the time to the external environment and what's in it. So this cartoon is just trying to demonstrate, and this audience is of course very familiar with this, the normal structure of the of the lung, showing the interstitium, the alveolar space. The blue cubes are kind of normally functioning epithelial cells that are able to control the environment and kind of maintain homeostasis. And there really is limited scar formation in that setting. Sure, occasional injuries may cause some scar that we see over time in lungs as they age, but it's not pathologic. In patients with IPF, something in the epithelium predisposes them to premature senescence, essentially, and they become dysfunctional. In many cases, we're learning now this is genetic. There also is probably a strong environmental component to this. Inhalational exposures over time. There have been epidemiologic associations with dust and other environmental exposures. It's probably a cumulative effect. And in some people, they in their 50s, 60s, and particularly 70s, develop this senescent dysfunctional epithelium. And then normal everyday stress, or perhaps some additional minor injuries, cause progressive fibrosis. So the lung is essentially trying to heal itself. There's still a lot we don't understand about this. There could be additional drivers of this, but many people feel that the primary abnormality focuses around the dysfunctional epithelium. So this model has helped us to think about IPF as a distinct and different form of lung fibrosis from other causes of interstitial lung disease, which by and large are thought to be driven by inflammation, to use the word kind of loosely, but by an injury process and a normal cycle of repair and scar formation. And in those conditions, the focus has primarily been on reducing that injury or that inflammation. In IPF, we've taken a different approach and really tried to focus on antifibrotics or therapies that suppress the kind of primary fibroproliferative process in the lung. And I hope more and more as we move forward, look upstream from that and actually focus on things like the epithelial cell and can we restore normal function to the epithelium or intervene and affect the way in which the epithelial cell signals and controls the local environment. So there could be a whole another series of grand rounds on this. I just wanted to set the scene for what we're going to talk about now, which is much more clinical, by positioning IPF as a disease that is primarily caused by repetitive stress in a dysfunctional environment. There are a couple of people I'm going to introduce in this talk, both along the lines of mentorship and also collaboration. So Ganesh Raghu, many of you in this field, most of you, maybe all of you in this field will know that name. Ganesh has been a leader in clinical care and clinical research for decades. And Ganesh is a unique and creative thinker. And many years before the rest of us, Ganesh recognized a relationship epidemiologically between patients with IPF and gastroesophageal reflux. I remember sitting in the audience at ATS listening to him speak about this, and nobody believed him because his hypothesis was that it could have a role in either the development of IPF or the progression of IPF. For years, this was discounted as an idea, I would say. And I think the lesson here, as you can decide as you see the evidence to follow for yourselves, but the lesson here to me is that people like Ganesh are really important to listen to. Doesn't mean all their ideas will turn out to be correct, but we need people who are creative, innovative thinkers who push the envelope and have, what sometimes we call high-risk ideas. And we need to find ways to pursue those as a community because some of them may turn out to be really important. So Ganesh has been an important partner and colleague in this, and I want to recognize his really foundational role in bringing this idea of gastroesophageal reflux and IPF to the forefront and to my attention. This is one of his early studies with colleagues from the University of Washington. just demonstrating this epidemiologic association, this increased prevalence of reflux in patients with IPF. See, this study is over 20 years old. And here's the primary finding from it. This dot plot basically shows the amount of, in this case, time at a low pH, which is a correlate of, or consequence of acid reflux, both in the distal and proximal esophagus, which you see there along the bottom, in IPF patients and in controls without IPF. And essentially this shows that I believe this is mean, mean value for kind of time below pH of 4 is higher in IPF patients than in controls. And in some patients, it's quite a bit higher. So this demonstrated this association that I mentioned before and led to the hypothesis of a potential causative relationship that, that I found really compelling. So this led me to focus on this as one of my niches in my research career. And I think this is another important take-home message, is to find something that you can make your own and that you can work to have the community associate with you, so that when somebody has a question about gastroesophageal reflux and IPF, they think, oh, I should ask Hal, or, oh, those are papers that, Dr. Collard has written. This takes time. It's not necessarily easy, but it can be deliberate, and I think should be. Look for things that interest you, that are important questions to answer, and then work to make it something that you are a expert in. And one of the ways you can really do that is by writing a review or a consensus piece. I think in my career that has really helped me both to understand the field and to have recognition in the community as someone who's thought about it and someone to reach out to for collaboration or opportunities to speak about it. So for me, this really was kind of came to the surface really around a case. And this is a real case that I saw around 2009. And a very typical presentation here is a 65-year-old, cough, some dyspnea, very typical IPF presentation. It's diagnosed actually by lung biopsy, which is what you see at the bottom, very small section of that, which shows this area of fibroproliferation that I'm circling called a fibroblast foci. Nowadays, we don't biopsy as many patients, but in the past, we did that a lot, and this patient had a biopsy. So this was before I saw him, and several years before I saw him. And so after that diagnosis, the patient's pulmonologist sent him for manometry, given his reflux symptoms, and a 24-hour pH study. And essentially that showed normal motility, so manometry was normal, but significant time with low pH, and a Demeester score, which, as many of you know, is a kind of conglomerate of various measures, of 39, which is quite elevated. Normal is less than 14.8. And in the field of gastroesophageal reflux, patients with a Demeester score that's elevated, who have reflux that is not responding to medical therapy or symptomatic despite medical therapy, often undergo anti-reflux surgery, or at least considered for it. So this patient did. This patient underwent laparoscopic anti-reflux surgery at that time. And essentially this was the course of the patient's IPF over the intervening time between the diagnosis and that surgery and when I saw them in kind of mid to late 2009. So essentially stable physiologically. This is the FVC in blue and the DLCO in green. And the cough actually improved. So the patient came to see me for kind of longitudinal care, but had not had experienced any worsening of their disease over a couple of years. Okay, so I have a question for you. My question is, do you believe that the anti-reflux surgery that this patient had stabilized their IPF? And I'll let this sit for just a couple of seconds. I'll give it about 5 more seconds. Okay. Great. So it could be that there are only about 10 of you voting, in which case, who knows the accuracy of this, but we'll take it for you know, a sign of the audience that it's maybe 50-50, a little more yes than no. But there's certainly, you could say, equipoise here. It's not clear. That's how I felt about it too. So this seemed like an area that was ripe for additional research. So the second person I want to introduce to you is Joyce Lee. Joyce came to my lab as a fellow. She was one of my first fellows around the time that I saw this patient. And as I mentioned earlier, really, I think the most important thing I've done in my career is in mentoring fellows. It's added to the quality of my science, the output of my laboratory, and my job satisfaction. It really has kind of multiplied, I think, any impact that I've had. And Joyce is a perfect example of that. So Joyce came into the lab and was interested in this potential relationship. And so, like I mentioned earlier, she started by writing a review article. This is one of the first things she did in the lab. And this is a figure from that review article, which, just as an aside, I'll tell you, I think it's always worth paying the really small amount of money it takes to have a professional illustrator do your figures. There is no way that I could have made this figure, but I think it cost me about $100. So remember that, and take advantage of it. And there are many, many good qualified illustrators out there. I think this figure was very helpful both to Joyce and to me, and to the many people who've seen it in talks over the years, particularly patients. I think it's fairly intuitive. So it shows the proposed or hypothesis behind how reflux is related to, or could be related to, lung fibrosis. Essentially, you have gastroesophageal reflux. It leads to aspiration, perhaps largely microaspiration that may be clinically silent, probably in the setting of some other predisposing factors, as I mentioned earlier, genetics and other things. But then over time, you have repetitive injury in the alveolar epithelium, or to the alveolar epithelium, from, as you see in the kind of blow up there, from acid, from food particulates, bile salts, pepsin. In other words, not just the acid of the reflux. And that over time leads to scarring in the lung. And it may even worsen reflux, because there is also a hypothesis that the more fibrosis that forms in the lungs, the more negative intrathoracic pressure is generated with respiration, and the more that affects reflux because of the pressure differential. So that's the hypothesis that we kind of underlied the studies that then Joyce went on to publish. And I'm just going to show you one of these, but this led to a series of publications that I think, on top of Ganesh's work, really set up the field for a more robust study, which is where I'll focus most of the rest of my time. She was very creative in how she approached this. She reached out for other cohorts from other collaborators, and really took advantage of the resources and cohorts available to ask some very, I think, important questions about relationship to outcome, relationship to other markers of reflux, and the impact of therapy. So I just want to show you one of those, which was a retrospective study of about 200 patients with IPF. This was between both UCSF and the Mayo Clinic. And the objective here was just to investigate the relationship between reflux-related variables, symptoms, medication use, for example, and survival time. About half of the cohort had symptoms or were on medications, and a small number of them had had surgery, this fundoplication surgery or anti-reflux surgery. So this Kaplan-Meier curve here shows that medication use for reflux was independently associated with prolonged survival time. So the dotted line is those taking reflux medication, the bottom line is those who aren't. And in some relatively basic but multivariate regression analysis, this relationship held up. But clearly this is hypothesis generating, but suggests that there could be a benefit to treating patients with reflux with anti-reflux medication. Particularly intriguing was this additional Kaplan-Meier curve, which showed the impact of the small number of patients, really just a handful, who had had Nissen fundoplication. So anti-reflux medication treats the acidity, of course, but not the rest of the reflux. Fundoplication, or anti-reflux surgery, would treat all of it. So the reflux would actually be gone as opposed to just asymptomatic. And based on the figure I showed you, we thought that it was likely that it wasn't just the acid that was potentially harmful and involved in the pathobiology of IPF. It could be a more complex mix of the aspirate. So this curve, again, showed even better survival among those who had had fundoplication, but was a very small number. And so importantly, at significant risk for error just from the potential for kind of random outliers in a small group. But it was intriguing, hypothesis generating. So the last person I want to introduce you to then is Kevin Anstrom. Kevin and I had met through what was called the IPF Net, or IPF Network, which was an NIH sponsored consortium that did several important clinical trials. Kevin is a biostatistician, and he was the principal investigator of the Data Coordinating Center for the IPF Net. So together with Ganesh, Joyce, and Kevin, we decided to pursue a randomized trial of fundoplication for the treatment of IPF. And that's what we eventually published now 2 years ago in Lancet Respiratory Medicine. So this was a phase 2 NIH funded study of anti-reflux surgery for the treatment of IPF, and never would have happened without the input and collaboration from these colleagues and many others. This was a 6-center study across the US. This was a really challenging study to do. And as I'll close with in a few minutes, I think going forward, we need different approaches to answering questions like this. This study from start to finish took 6 years. It enrolled just over 50 patients and randomized them to anti-reflux surgery or no surgery. So this was not a blinded study. We did talk about that initially, thinking, could we do sham surgery? And that was really a non-starter. So we ended up randomizing between anti-reflux surgery and no surgery, but allowing standard of care. So as deemed appropriate anti-reflux or anti-acid medication for any and all patients enrolled. We thought about studying antacid therapy, but because it's available over the counter, it was really hard for us to figure out how to ensure that the placebo group wasn't taking it just over the counter. So we ended up with this design, both because of that and because we felt that surgery was likely more impactful than just medication alone. So we enrolled patients across 6 centers. All of these patients had significant gastroesophageal reflux by 24-hour pH. So that's a really important caveat to the inclusion criteria. We followed them over 48 weeks, and the primary endpoint was change in their forced vital capacity, which many of you know has been the primary endpoint for most IPF studies, most ILD studies. And then as secondary endpoints, key secondary endpoints, we looked at some of the important clinical markers in IPF: acute exacerbation, which may be linked to aspiration events, hospitalizations, changes in symptom scores, death. And then we also looked at the kind of safety and complications or effects of the surgery. So I'm just going to show you 2 slides of results. The first is the primary endpoint, which was decline in forced vital capacity. If you look at the graphic, it looks, at least to me, pretty impressive. It looks like it cuts the rate of decline in FVC, which is what you're seeing from left to right, about in half, which is, just to put it in context, the same thing that was seen with the antifibrotic medications, nintedanib and pirfenidone. So instead of 130 cc's over 48 weeks, it's 50 cc average decline. So this is where it's really important that you look at the number of patients and you look at the analytical approach and statistical analysis. And so the primary approach here showed a p-value of only 0.3. So although the estimates of change were kind of quantitatively different, the likelihood of this being being real was still fairly questionable or low. Certainly not something that we would accept as proven. This also illustrates, I think, one of the challenges in any clinical trial or any clinical research, which is depending on the way you do the statistical analysis, you can get different results. And while there are very good arguments for using different approaches, and in fact, I think given the way missingness ended up happening in the study, actually this worst rank analysis was more appropriate. This was done ad hoc, or post hoc, sorry. So it is at risk for kind of being selected even subconsciously by me and others who were trying to be objective as the best analysis because its p-value was low. So I think we have to be skeptics in looking at this. And to me, this says, there is possibly an effect there, but it's not proven and needs additional study and probably larger numbers. I think intriguingly though, the clinical endpoints all trended in the direction of supporting surgery. Now, talk about low numbers. Here it's even lower. The number, for example, of acute exacerbations in the surgical arm was 1, and in the surgery arm was 4. So taking that alone, it's very high risk for just randomness. But looking across all of the endpoints, you do see that relationship hold up. Respiratory hospitalization, which weren't all exacerbations, but there was definitely overlap there. Death, decline in FVC, cough severity, all of those trending support the surgery arm. So I think in total, taking all of the data, you can decide for yourself. To me, it's certainly suggestive of there being some benefit, but I think, again, not proven and in need of further study. Importantly, the surgery seemed to work. If you look at the change in the Meester row, it did reduce reflux. The patients who had surgery had repeat pH study done about 6 months into the study, and it showed a significant reduction in their Meester score. There was the expected postoperative dysphagia, kind of the expected abdominal distension. These were transient. And there were 2 patients who had complications. Both of them were actually thought to be unrelated to unrelated directly to the surgery. One was someone who had been on steroids unknowingly and had some adrenal insufficiency. And the other was a readmission for some bleeding, which was of unclear relationship to the surgery, but essentially very safe and manageable procedure. Okay, so I made this point already, but again, for the junior members, collaboration, I think, is my next to last take-home message for you. Clinical research is definitely a team sport. The science and collaboration makes good projects great. And I just want to push back against the concept of not sharing results because of fear of getting so-called scooped or having somebody take your finding. I'm not saying that doesn't happen, but my experience is that that happens less frequently actually if you share ideas and work with others, because more often it leads to collaboration, more often it leads to better ideas on your part, and therefore more kind of rapid and high profile publications. So I'm a strong believer in collaboration in open science. I think this is a really important component of success. Okay, so I'm almost done. I'm going to clear that old response, and I want to ask you now, after I've shown you the data from Joyce and from this trial, ask you the same question. Good, so some of you are already answering. Do you believe now that anti-reflux surgery stabilized that patient I showed you with IPF? Okay, now I'm gonna wait because I can't believe all of you are saying yes. Thank you. Good. So I don't know how many of you voted again, but I'm going to also, in the interest of time, I'm going to close the poll. And I think, yeah, you know, this is good. Okay, so 80-20. This is kind of where I fall too, I think. I think that I'm more convinced, but, you know, is this enough to actually recommend it? I don't know. And clinically, I have a real hard time. As a researcher, my answer is clearer. As a researcher, I think my answer is we need more research. I'm not convinced. As a clinician, I have more trouble. I think patients who have IPF, who have evidence of progression, who have significant reflux, I often will recommend that they consider this. And my approach is to share with them these data and tell them that I'm not sure, but that I feel like more likely than not, it's helpful. Clearly explain to them the risks and then let them decide. It's an uncomfortable position to be in as a clinician, but I do feel like given the natural history and significant morbidity and mortality of IPF, that unproven but likely therapies are still worth considering. You may feel differently. I think the critical thing is to understand the data and make that decision with your patient and you know, give them the opportunity to weigh in. So just to finish out the case, this patient, it was remarkable, remained stable for 6 more years. And then finally in 2015, the patient had what I think was an acute exacerbation, had a flu-like illness and had acute worsening, was all of a sudden oxygen dependent, remained that way, and then had progressive decline, died in 2017. So 10 years from the time of diagnosis of IPF. I didn't show you the natural history curve of IPF. That's an unusually long time to survive with IPF. It's not unheard of, but it's an unusually long time, as is the stability that he experienced. Again, not unheard of, but unusual. So again, an anecdote that you can take for what it is. So my last 2 slides are first, where do we go from here? So what does the next trial look like? I have really struggled with this, and I have not been able to put together the next step. Now, part of that is my professional responsibilities changed and the direction of my career changed, but this is a frustration to me. And if any of you listening are interested in this, committed to this, I would love to discuss it. I think there are real challenges to the next step being a traditional randomized controlled trial. As I mentioned, the WRAP trial was very difficult to enroll, was very time consuming, was very expensive to do all of this kind of outside of usual medical care. I just don't see the funding for that being available. I don't see the NIH you know, having that kind of funding, and nor do I think, honestly, they probably should be funding something that expensive as a clinical trial. And I don't see a sponsor supporting this because I don't see a commercial advantage. Not that that's their only motivation, but they have to have some commercial advantage. So then, you know, is there a pragmatic approach? Could we utilize the health system to randomize patients through the course of their usual care to fundoplication surgery or not? I think this is much more viable. And maybe this is something that you and your institution have experience with. There's certainly lots of institutions now working towards real partnership between the health system and researchers and looking at utilizing the tremendous patient volume and resources of the clinical system to ask important questions. I think that's very promising. And the other one to mention, which I'm more skeptical about, but it's gotten a lot of interest, is the idea of using real world data, essentially non-randomized designs, to essentially conduct a trial with the idea that with enough data and enough kind of resolution into patient experiences and covariates, you can answer some important questions with real world data. I think this is worth exploring. Part of my skepticism is lack of insight and knowledge in this area, although this is one of the key places my lab is moving towards, or areas of research we're moving towards. I do think this is worth real consideration. I also just want to mention, can we improve trial efficiency through technology? I think the answer there is yes. Just one example is mobile spirometry. You know, right now in these trials, we have patients generally come back to clinic to do spirometry, which is our primary endpoint. If you give them a home spirometer, they can, it's feasible, it's well kind of tolerated and understood by participants, and it allows you to measure that endpoint much more frequently. And as many of you know, the more frequently you measure an endpoint in general, the smaller sample size you need for the same kind of statistical resolution. So I think this is a real promising approach, both in traditional trials, but also in trials that of any kind, where you want to measure something that currently requires patients to come in to another facility. Using mobile technology, wearables, is really powerful. And then lastly, can we think about sponsorship or participation in novel ways? The model here I think of is the NET trial, lung volume reduction trial, where really delivery of an intervention was linked to, or payment for an intervention was linked to participation in a study. There are real challenges with doing this, but it is a model that has worked. There is a mechanism for it. And maybe some of you have experience with that. So I think we need to think creatively. This is a very challenging next step, but I hope we take it, because I think scientifically there's still a question. And so to close, I want to leave you with this last take-home message, which again, I firmly believe in, is to have fun with what you do. You only live once. That we certainly know more today than ever. Keep things in perspective, again, particularly for junior faculty. Remember why you got into this business, the incredible opportunity we have to work with patients, to ask questions, to be creative. Remember that and enjoy it. Your career in your science will be better for it, be more rewarding. Don't take yourself too seriously and enjoy the journey. And so in my thank you slide, I just want to show some of the people I'm enjoying this journey with. These are fellows and colleagues from across UCSF and elsewhere. So thank you very much. I'm going to pause or stop there. And I think we have about 10 minutes for questions.
I think we see I think there's a question there in the chat. Al, you can see it. The question is, in your experience, is magnetic clip placement, is it safer versus fundoplication for surgical management of the gastroesophageal reflux disease?
That's a great question. I was interested in using that. I don't have my own clinical experience with that approach, but I've talked closely with our surgeon here, who was my partner in the trial. Well, first I would say fundoplication is safe for this population, but magnetic clip placement is easier and just kind of less even immediate morbidity. So I think it's well worth thinking about, and it may be more feasible as a way to move forward. That's all I can really tell you. I don't have a lot of experience with it.
There, we have a question. Do you see the question from Dr.?
Yeah, I can. Yeah, question from Alan about how are you best thinking about timing of interventions for IPF? Well, I'll just briefly say, I think, in general, my feeling is that interventions, you should consider interventions, both pharmacologic and other, at the time of diagnosis. I believe that IPF in any patient is unpredictable and is active, even if you have several years of stability to look back over. And the problem in IPF is if they progress, you never get it back. We don't think that you can have improvement in lung function with therapy for IPF. It's really about, at best, stabilizing them where they're at the moment. So most patients, because particularly medical therapies are safe, are interested in and decide to start therapy early so that you have the greatest chance of preserving the most lung function. And I think that should apply across kind of all therapies. If it's something you would consider in this patient, consider it at the time of diagnosis. Unless there's some, situation in which there's particular risk to that. And I guess, like always, it's about balancing benefits and risks. Then I see, Pat, do you want me to just, there's another question here about fundoplication on patients with esophageal dysmotility.
Please.
Yeah, that's a real important issue. And really, there are many ways, as you may know, to do the fundoplication. There's a traditional fundoplication, then there are modifications that can be used in patients, let's say, with scleroderma or other dysmotility. But there also are patients with esophageal dysmotility that shouldn't have a fundoplication. So this is where it's really important to have an experienced surgeon or gastroenterologist who knows about kind of risk stratifying and surgical treatments to make this decision with you, because there are some situations in which it could be harmful. Yeah, there's a question here about, would you advocate for pH monitoring for everybody with new onset IPF? No, I don't. I only will do pH monitoring on patients with symptomatic reflux or who are on anti-reflux therapy. So in other words, who I have high clinical suspicion will have an elevated Demeester score. You could look at the data I presented to you and come to a very different conclusion. I think this is one place where I really struggle with the logic of it. But that's how I practice currently. I send people who I have a higher index of suspicion for significant reflux. And if I think about it honestly, even it may be those patients who also have some evidence of progression, although that's I would say that's less of a consideration for me. So I still do have a bar to clear, I guess, in terms of thinking about who I send for pH study. What is the role of acid reflux versus non-acid reflux in IPF? Great question. I also think that's unclear. The hypothesis we have is that all of it is relevant. And it may be that what we see in the kind of association and epidemiologic data support that, where medication alone has some impact, surgery has more of an impact, and the data for that are very limited. So I don't think we know. I think it is important to recognize, though, that acid is not the only potential injurious component of reflux. And so thinking that you're eliminating that risk by putting them on anti-acid medication may not be the case. But it may be helpful because reduced acid may reduce the overall amount of injury that's happening. There's another question about, does IPF improve with the use of proton pump inhibitors? Yeah, no, we've never seen improvement, at least over average or over groups of patients with proton pump inhibitor therapy. Most of the therapy in Joyce's paper that I showed you was PPI therapy. Only a small number were on H2 blockers. So probably the data support a slowing, but not even a stabilization with PPI therapy. I think, Pat, that might be all of the.
So Hal, can I ask you a broader question, since we have just a few more minutes? You've obviously been on the leading edge of what's happening in IPF, and we all agree, as certainly as pulmonologists and even as internists, how complex of a disease it is. It's pretty challenging. Could you take just a couple of minutes and just give us maybe a little bit of a peek into what you see coming down the pike for IPF, whether it's therapeutics or diagnostics, just from a broad perspective, since we have a fairly broad audience?
Yeah, great question. I'm actually just writing a chapter about this, so I'm thinking about this a lot. My answer is going to be some combination of hope and expectation. So some of this, there is promise for all of this. Whether or not it'll really happen, I don't know, but I'm hopeful. First of all, diagnostically, I really think that molecular diagnostics will become an important, molecular and genetic will become an important component of diagnosis. We already know that many patients with IPF have genetic abnormalities that affect the telomere length. So whether they're in the telomere specifically or kind of the associated genes. So I think that is yet to be determined exactly how testing for those mutations impacts the diagnosis, but many of us are integrating the results of genetic testing into how we think about whether a patient has IPF or an alternative diagnosis. I also think that molecular profiling, peripheral blood biomarkers even, have real promise. There have been a long litany of papers looking at that. It's been very confusing, but I think we're making some inroads into identifying a panel that's useful. And there is now, as many of you know, a commercial panel for a molecular analysis of diagnostic of lung tissue from transbronchial biopsies. And that has just had another recent publication on it. I think there's still some questions, but I see all of that as evidence of what I believe actually fundamentally, which is that we need to move towards at least in molecular and genetic diagnostic approach. There are so many cases, as you and others know, where clinically we can't tell what the patient has, even if we do a biopsy. That's really unacceptable. And we should be able to tell if we could understand the biology of what's happening. So I think on the diagnostic side, I would say that. On the treatment side, just real quickly, I think that there are luckily, a number of companies and investigators still committed to identifying newer and better therapies. I think that the drugs we have are important, but they're not cures and they're not good enough. We need therapies that are probably additive. I think we'll see kind of a combination therapy approach down the road, a cocktail approach, probably not monotherapy. And I really hope, Pat, that we start to see therapies that look upstream from at least how we think the current therapies work. We think that the current therapies are largely targeting kind of the end result of the pathobiology here, which is the fibroproliferation. As I mentioned, I think there is a potential for real impact upstream, even potentially targeting the alveolar epithelium. So thinking about, how can we impact that perhaps, more the driver of the disease seems critical to me as an additive to this downstream kind of slowing of the consequence of the disease, which is the fibrosis. So I think there's a lot more I could say about that, but that's where I see things moving. I think a combination of therapy, molecular and genetic diagnostics, and hopefully all of that means getting people earlier, more accurately identified, and further slowing the progression, maybe even stabilizing the condition.
I think that's a perfect way to end. Hal, I really want to thank you for taking the time. I know how busy you are. Fortunately, we have these ways in which we can connect. It is, as we discussed earlier, it's a bit impersonal, but nevertheless very, very valuable. So I can't thank you enough for taking the time and speaking with us. And I certainly hope that at some point we'll be able to do this in person for sure.
Thanks, Pat. It's great to see you personally, and thanks to everybody for listening. Really enjoyed it.
Great. Thanks everyone for attending. Have a great day.